I now have the honor of introducing Dr. Gregory Welch from the University of Central Florida. I'm very excited to hear your presentation, Greg. It's, I think, the power of using virtual patients to help with simulation training, to help people understand, not just the mechanics of healthcare, but the soft skills needed. So welcome, and we look forward to hearing your talk.
Thank you, Walter. I really appreciate it. And hello to everyone. Thank you for the opportunity. I control the slide, so Walter, you'll wave your arms if something is not going right. You let me know. One point I want to make to folks before I launch is that I'm in the College of Nursing. That's my primary appointment, but I'm a little unusual in that I am not a nurse by training. I'm a computer scientist and an engineer, so I have a bit of an unusual position. Not totally unusual, but a bit, and it's great fun. I love it. All right, so I wanted to talk to you about 3 themes today, and clicking is a little delayed. It'll take me a minute to get used to this. Simulating patients is the first of the 3 themes. And I'm going to give you kind of a highlight of some of the work we've been doing in these areas and why it interests me, why I enjoy sharing it with people. The first is a thing we call the physical virtual simulator. And as it says, human-shaped physical form of the virtual patient. And I think the best way to explain it is to show you a little bit of what we mean. So 3 options here that people are probably very familiar with. You can either have a real human actor or somebody that would be more than an actor. It's a trained person who's a standardized patient. We can have physical mannequins that are robotic. They can exhibit pulse and iris changes and all sorts of interesting things, but they're plastic and they look plastic and they don't cry overtly in their face. They don't exhibit emotional facial responses or nonverbal behavior. And then virtual patients on the right-hand side, you can have all sorts of expressiveness and flexibility, change race, change gender, change all sorts of things, but you can't touch it. There's nothing physically there. It is just in the computer, if you will. And so what we've been working on is something we call a physical virtual patient simulator. And I'm just going to play a short video here to give you a sense of what this is like.
We present a generalizable method to detect and respond to multi-touch with low latency on a human head surface. Our prototype rig uses infrared lights, cameras, and projectors. A lookup table provides correspondences between the spaces. We create an animatable model and register it to a point cloud triangulated by the cameras. A virtual camera sends images to the projector. The rendering system updates as the point of touch varies.
So the important things to realize about that is that it is a physical object that's in front of you. It's the shape of a human. If you closed your eyes and felt it, it would feel like a human. And when you look at it, the imagery on the surface represents a human. All of their emotions, if they cry, if they have skin blemishes or different symptoms that are visual in nature, they will show up there. We also have sound. We have tactile aspects of pulse and other things. We have breathing. We can change the temperature on the surface of the patients. We can make them feel like they're going into shock if their extremities are cold or forehead might be warm or something like that. Another example of it being used here for stroke diagnosis, some experiments we did.
Can you smile for me? Very good. While you're smiling, I'm going to go ahead and examine your gums. I'm going to look at the lower lip and the upper lip. Very good. Now I'm going to take a look at your eyes. The sclera is nice and white. Now I'm going to look at your upper lids. Very good. Everything looks normal.
So one of the things I tell people about what I like about the stroke example is if I'm somebody who's trying to learn how to diagnose a stroke, and I'm not a medical person, I'm getting there slowly, little tiny bits. If you show me a picture of a stroke victim, a patient, the asymmetry in their face is going to be really obvious because you're looking at it typically straight on and you can make a judgment about how asymmetric things are. But clearly that's not the case when you approach a patient in a clinic room or somewhere else. You don't necessarily see them from that perspective. You might look at them from one side or another. And so I find it interesting that there are situations like that where presumably the people, the practitioners, the nurses or the physicians have to learn to position themselves to look for those things, that it isn't just as obvious as it is often in the training material. So we've also taken this in different directions, but one of them is we've built a pediatric version, pediatric prototype, which also has the temperature control, the pulse, and all these other wonderful things. And we've done a variety of experiments using this. It's of course important because children in particular, as I say here on the slide, it's hard to simulate children. I mean, we can have pediatric robots, but we can't really have pediatric standardized patients because we can't have kids. It's not allowed. And one of the things that I wanted to point out here too that I find really interesting is some of this work was motivated by, from a human interface standpoint to a simulator, the ability to present the trainee with a complex combination of cues that in and of themselves would be very subtle. So for example, if it's a case of sepsis or something like that, any one of the individual cues, the shallow thready pulse or all these other things might in and of themselves lead you to one thing, but when taken in their totality should, especially in the context of this child's just been in surgery or something else, should help you understand that this is a likely outcome, is this infection. And so I'm really excited about it and like the idea that we can bring a lot of these modalities, the touch, the sound, the feeling, the tactile, the visual, all together into one place. So the next category I wanted to talk about is now, instead of just simulating patients, how about comforting them? And by the way, I want to point out that in the three categories I'm giving here, they're not necessarily all like bins that are exclusive of each other. There are things that cross across these boundaries, obviously, and there are uses that cross across the boundaries. But in this category, a little story here inspired by COVID-19. One of the things that happened was, these are some of there's a faculty member on the left, Professor Ryan McMahon, and the other 4 individuals are undergraduates working on this project with us. It's a long story, but it's wonderful. 4 undergraduates funded by the National Science Foundation, a grant to work on this with us. So back to the story. I realized as the pandemic began, I and many other people, I was watching as a computer scientist, people dying in isolation and watching the news and hearing about families who are unable to be with their loved ones, and their loved ones are all alone, and there's obviously nothing directly I can do about that. But one of the things I realized is that the primary mechanism that was connecting people was, for example, FaceTime or some sort of video teleconferencing. And I thought, well, that's a nice step. That's wonderful. It's better than nothing. But how almost frustrating it must be when I can see the person I love there and I can't touch them. I can't rub their head. I can't hold their hand. I can't reach out to them. So it's frustrating for me as the loved one who wants to comfort the patient. And it's also frustrating, or maybe it's not for the patient. Maybe they don't know any better. I don't know. But it's certainly frustrating for me. So really started thinking about human touch, the importance of touch, both to what we sometimes call the visitor, the outsider who's healthy, who is trying to comfort the patient, and then the patient themselves. That comforting the outsider to me is something that is really kind of a new thing and fun to think about, that the benefit isn't just to the patient, it's to me too. I'm helpless, I'm stressed out and there's nothing I can do. And it's very stressful and frustrating. And to give me the opportunity to connect in this way, we think could be useful, could be helpful to people. So we've done some prototyping, built some things, and done some small scale tests, limited by, of course, COVID, our experiments, and also limited by the ability to obviously access real patients is very difficult. And this is a relatively small effort. But here's the basic idea. On the visitor side, you have something that could be like FaceTime. It's a tablet or a smartphone or something that has the patient's face in it. So you're seeing video of them. And on the patient, you see maybe little indicators of where you can touch. And if you touch on that place, on the forehead, for example, and rub, that touch will be transferred over the internet to that person and onto what we call a tactile headband in this case that they're wearing. I'll show you in a second, but a headband. And so they will feel that squiggly line as I'm tracing, or if I'm going back and forth, the patient will feel that going back and forth. Of course, in a communication sense, there's a closed loop here, because if the patient is conscious and you're doing that, they may react to your touching. You're going to see them react to your touching. So it's giving you feedback that you're succeeding and that you have some effect on the patient, which is part of the comforting of the visitor, not necessarily the patient. I'm actually able to do something. So I have a tiny bit of control, if you will. So then here's an example of an early prototype. You can see on the left the actual person with the tablet. and the patient, simulated patient, lying in bed there, and she's got the tactile headband on. On the right, you see a little bit of some of the technology. We use a little computer and some chips and some little tiny transducers that generate tactile sensation. They're little motors that spin, kind of like your phone when it vibrates if you're, get a phone call or a text or something like that. It's the same sort of feeling, but we have several of them, 8 in the headband, and they're controlled individually and proportionally to kind of move the sense of feeling around on your head by changing the amplitudes of these different motors, the amplitude and the timing of the different little transducers. So a little example here, we did some to see if it was working and also to get some insights into humans' ability to detect different resolutions of touch. Can I only detect touch or no touch, or do I have a fine ability to detect fine motions? And it turns out it's pretty fine. You see here, we have a vibrotactile rendering. That first triangular plot there, that sawtooth plot, is what we sent to the headband, to the subject that she's wearing there. And on the right, the subject rendering is what she sketched out on a piece of paper to illustrate to us what she thought she felt on her forehead. And so we have we did several experiments with this, and I'm just giving you a couple of examples of tracing out some different symbols. The color here means timing. So it's, if I remember right, orange is, or blue is the start and orange is the end. So in the very bottom one, you can see it was 2 fingers coming into the center instead of just a single finger. But all of it turned out to be surprisingly effective in terms of our ability to affect the touch sensation and the patient's ability, or the human's ability, to recount for us what it was that they felt. We have put together a kit. We don't show it here, but we've got a flight case and some other equipment, and we're very close to putting it in the hands of some colleagues of mine, nurse faculty members who also practice. And so they are going to take it to the hospital, one of them in particular, take it to a hospital where he works 1 day a week, to demonstrate to other clinicians, not to use on patients, but just to get their feedback on it. And so we're anxious to get that going. And of course, we had to robustify it. We had to try and make it so that it was as standalone as it could be. And we're very close to that simple deployment. So the last thing I want to talk about, and this is something that excites me and touches in a lot of other areas of work, is what I characterize as assisting patients. So assistance, help me do something; companion, be with me; and an excursion, so allow me to get out of wherever it is I'm trapped at this moment if I'm isolated. Those are kind of 3 things that go together in this example. The virtual assistance is the first thing I want to talk about. We've done quite a bit of work on looking at, in my lab and my students and colleagues, on looking at controlling things in your environment. So if you're in the hospital, you're in your bed, you might have a little clicker, a little tethered control unit, so you can change the TV channel and do things like that. But what we've been exploring is the impact of having the appearance of a human doing things for you. So in the left here, you see a real human. She's turning on the light, for example, and she's like controlling something on the television screen. But if the light is controlled by an Internet of Things or a home automation controller, if you will, or the TV and things like that, I can put on an augmented reality headset and look and see a virtual human who walks over to the light and appears to turn on the light switch or appears to be controlling the TV. So, it's not essential, but as it turns out, there are a lot of behaviors like that that really affect my confidence that this thing was done, that affect my feelings about somebody being with me. And so companionship is wrapped up in this at the same time. And so there are quite a few benefits with respect to that. We also have been thinking about and looking a lot at just companionship. So forget assisting me with anything. On the right here, I've got 2 children. Imagine you're a child, or you have a child, one of your children, say, for example, who's isolated in the hospital room. You can't be with them all the time. Nurses can't be with them all the time. Doctors, nobody can be with them all the time. So imagine that not just one virtual human through an augmented reality display was with them in the room, or perhaps on a tablet with them, but imagine 2. And why 2? The reason is because if it's one child with you, there's this added sense of maybe social pressure. Like, I have to entertain them. Like, I'm their host. I'm always on. I always have to kind of be there, and they're just staring at me, and it's weird. But if you have 2, they can be playing with each other, and that can be totally scripted. But they are playing with each other and having a good time, laughing. Maybe occasionally they turn and attend to me, but I'm not under any social pressure, and I have this comforting sort of sensation of being with these other people. So I can tell you more about that some other time, but we've been doing some work in that area that I'm really excited about. This is very hot off the presses. We've just started talking with a couple of organizations, actually connection through Walter, through at least one of them. The Sanofi on the left is a company, an organization out of Rico Labs, like Ricola, the cough drop, if you might be familiar with. Family started a non-profit, not-for-profit organization to do good things, and Sanofi is one of those offshoots. This is my understanding. And they focus on developing, I'll call them excursions in the context of what I'm talking about, for senior citizens or for seniors, for elderly people who are isolated in general, that maybe at a care facility. So they develop a kit where the caregivers can open an iPad or a tablet, put on headmounts onto the residents, and take them to New Zealand or take them to some, interesting place, and they can look around and, kind of experience being at the beach or the mountains, Mount Cook or whatever it might be. They have this amazing fun. So lower right, Helping Hands, Monkey Helpers. It's a little strange because this organization started, and as their name indicates, by providing capuchin monkeys to people who are, for example, paralyzed, so paralyzed from the neck down. So really immobile in the house, the monkey can act on your behalf. Can they do things for you? You can turn on the TV, turn off and on lights, and do a variety of different things. We can all imagine that monkeys are cute and wonderful, but they also have a lot of baggage that goes with them. Some of the baggage we'd rather not have around our house, but so they're difficult in many ways. That doesn't matter because by law, for all sorts of reasons you can imagine, that's going away. So this organization is really interested in sort of what's next in terms of helping patients, these individuals who are isolated and unable to do a lot of the things for themselves. So it's helping that individual and helping the family, the caregivers around that individual. So what can we do to help them? And no surprise, virtual reality and augmented reality is something that they're interested in. And so we've been discussing with these folks, we've connected them up to each other, and we've been talking with them about this idea that these excursions would be useful and interesting to both of these populations and others. But for the moment, let's just talk about these, the seniors and those who are isolated because of mobility difficulties. One of the things that is sort of lots of things, as you guys know, things come around, like you work on something a while late, and then later it becomes relevant again or useful. And here's an example, some work we did several years ago, 2019, and that time frame, that was looking at ways to control head-mounted display content for people with limited mobilities, people who are paralyzed, for example, from the neck down. And why does this matter? Well, it matters because VR and AR is sort of inherently all about my being able to move around and change my viewpoint and turn my body and look behind me and look down and react to things that happen. But those who have these mobility limitations, if they're paralyzed or whatever, can't do a lot of those things. So they may miss out on a lot, right? Things may happen behind them, things may happen over here. They want to go look here, but they can't easily, or they don't know that they should go look there, as some of us might do. So we've done a lot of work on like mechanisms for controlling and changing the content for people who have mobility limitations. One of the things I find that turns out to be very compatible with, if you could do this, if you could give people the ability to control these different environments, is now those people would have a better ability to go through these different types of excursions. And that would include, as I show here, real excursions. So they're probably pre-recorded, but it's a 360 video of a real place. I can watch the sunset, I can watch the beach or something like that. In the middle, maybe I can do a virtual environment excursion. So I could be an excursion, I could be on an excursion to an imaginary place, some artificial city with artificial people who are doing things. Or I could actually go on a live excursion. And this is not new in general. People have done this with tablets. There's a telepresence robot here on the right that's made by a company called Double. There are quite a few of them. This is just one. And, maybe if I'm sitting at home immobilized because I'm paralyzed or whatever, sometimes I can go to the mall, but of course it's a pretty big ordeal. Got to get people, got to get the van, got to get all this stuff, but maybe periodically I can go to the mall through one of these robots. And so if I can control the robot with my head, using some of the techniques that we've developed, it might be a more satisfying experience for that individual because they're actually in control of this particular experience. So we're excited to look at a couple of these things, but one of the things that these often have in common, or the two of them have in common. The first is you get only dynamic viewing in the pre-captured reel. When I say only, I mean typically. So I'm not interacting with the scene, I'm not touching the bushes, I'm not causing anything to happen in there. I'm just a passive observer and I look around. But if you look at the other two, they have in common that I can potentially interact with some of the things in the scene, or things in the scene are happening that I want to interact with. So it kind of goes both ways. I see the dog, I want to touch the dog, or I want to interact with the dog, or the dog is leading me somewhere. And on the right, of course, I want to control the robot. I want my robot to go into the store. I want to look at the ties over here, and I'd like the salesperson to know I'm there and come over and talk to me and all of that. So there's this interaction that's going to happen in these two cases. And so one of the things that we find interesting is that in these experiences in general, if you have limited mobility, you're not going to, as I said earlier, you're not going to know potentially that someone was behind you or that something was happening behind you. So that's a general problem for people who do these 360 or these immersive experiences, but it's particularly a problem for people who are physically unable to rotate around to look at things. So one of the things that we've been looking at, and this is a PhD student of mine who's actually about to defend very soon, and in fact, in a couple of days, 6th of October, is going to present a paper on this at the International Symposium for Mixed and Augmented Reality, and ISMAR, is work using curated diegetic, that means natural to the scene characters in these scenes to help me be aware of interesting things. So we call it guiding, but it doesn't have to be so explicit. It can be very implicit, but the dog's behavior brings to my attention things that might be interesting to look at. And the dog is diegetic. It doesn't seem out of place. So the dog seems to belong there. Dog is a plausible addition to, to many scenes. So I want to show you a little video of this here and you'll get an idea what I mean. All right, and I get to see everybody dancing, and then they finish up their dancing, and they all go away, and the dog comes back to me. So the dog can always be sort of my scout, if you will. It's always helping me spot these interesting things. So we're really interested in looking at that with respect to these sorts of at least these three classes of experiences. I think another interesting thing that's just looking ahead, one thing I like about some of these things is that people in the outside world, if you will, that individuals who want to volunteer, want to help these isolated patients or these isolated individuals could do so. So I think one interesting thing is when you look at some of these things, the first two, for example, you could imagine that there are individuals who want to provide experiences for those isolated patients or the isolated individuals in their home. So they might specifically collect material at exotic places, maybe at the request of some of those individuals, maybe just because they happen to be there. Interactive virtual content, you could have people that would be creating virtual worlds specifically for some of those people someday. So that's, I think, an interesting, appealing thing. I think a lot of people, I know students at this university would love to do something like that. You could even imagine volunteers who on a dedicated basis every Saturday, they alternate or something, and they take one of these robots to the shopping mall, and many people around the country get an hour or half an hour, 30 minutes or something, excursion to the shopping mall. So that same volunteer stays with the robot for half the day or the day, while different individuals sort of multiplex in, switch in and out of the robot. So that's something we're really have fun thinking about, the possibility for that. And the last thing I just want to share is the notion that, of course, this doesn't have to be limited to just those uses or those sorts of populations, that isolated folks in general, and this is not new. We didn't think of this, but people use these telepresence robots, for example, for children who maybe they have an immune issue or something like that, and they can't attend class. So I can use this robot to attend class. So anybody who's homebound for whatever reason, they would love these excursions also. Or hospital bound, for example. I'm stuck in the hospital room. I'm not a child, but I'm an adult who's bored and stuck. Now I can have these virtual world excursions, and maybe I can even use my telepresence robot or some other mechanism to have these real world excursions. So I get out of the hospital room for a little while and go do these other things. So that I will close up and take questions if anybody has any, and I'm always happy to discuss offline if anybody wants to reach out to me. I'd be happy to have a chat later. So thank you.
I don't see any questions from the crowd at this moment, although they could still come in. Greg, thank you so much. That was very informative. It's amazing to see all the different work that everybody's the different speakers are doing in these areas, and it's really just I love being able to be together and collaborate on these things because it really gives me ideas about how we can keep moving stuff forward.
And I mean, there's not a question. I'll just say that I love that I have straddle this sort of tech world and the nursing folks, because as a tech person, I always love good problems and I want to help people. I want to do good, but I don't know how to do it. I don't know what they need. And so, working with these folks who are learning about the tech and then I'm learning a little about them is really a gift. It's really a fun situation to be in.
Awesome. Thank you so much for being with us.
Thank you.